Hello and welcome to Axonovyn. Hit that subscribe button and start your journey into the incredible world of the brain with us. In this episode, we want to talk about MS treatment. As we described in the first episode, multiple sclerosis or MS is a chronic inflammatory demyelinating disease of the central nervous system or CNS that can lead to progressive neurodegeneration. Current pharmacological approaches primarily aim to modify the disease course by reducing relapse rates and slowing disability progression, manage acute relapses, and alleviate chronic symptoms associated with MS. In this video, we will provide a detailed overview of disease-modifying therapies or DMTs, their mechanism of action, and their clinical applications, as well as pharmacological strategies for symptomatic management. DMTs reduce the frequency of relapses, delay the onset of disability, and attenuate MRI visible disease activity. There are many categories for DMTs. First of all, injectable agents. One of them is interferon beta 1AB that can reduce T cells activation and stabilizes the blood-brain barrier or BBB by decreasing pro-inflammatory cytokine production. Glatiramer acetate acts as a myelin basic protein or MBP decoy, promoting the differentiation of regulatory T cells or Tregs. The second classification is oral agents. Fingolimod is one of those agents. Fingolimod or S1P receptor modulator prevents lymphocytes from exiting lymph node, reducing CNS infiltration. Dimethyl fumarate exerts neuroprotective effects by activating the nuclear factor erythroid 2 related factors 2 or NRF2 pathway, reducing oxidative stress. Teriflunomide inhibits pyrimidine synthesis, limiting the proliferation of activated T and B lymphocytes. Cladribine targets rapidly dividing immune cells, resulting in selective immune cell depletion. Third classification is monoclonal antibody therapies. Natalizumab, a monoclonal antibody against alpha-4 integrin that prevents leukocyte adhesion and migration across the BBB. Ocrelizumab, a CD20 targeting monoclonal antibody that selectively depletes B cell implicated in autoimmunity. Alemtuzumab targets CD52, leading to broad depletion of T and B lymphocytes. There are many treatments for relapse management. One of them is corticosteroid. The mechanism of that is inhibits pro-inflammatory cytokine production and stabilizes the BBB, rapidly reducing CNS inflammation. Clinical use of that is administered in high doses for 3 to 5 days during acute relapses to shorten relapses duration and accelerate recovery. Another one is adrenocorticotropic hormone or ACTH stimulates endogenous corticosteroid release, used when high-dose methylprednisolone is contraindicated. There are symptomatic management for patients with MS. Pharmacological management of MS symptoms is essential for maintaining quality of life. Common treatments include amantadine, modafinil, that is a dopaminergic stimulants, and they are effective for fatigue. Baclofen, that is a GABA B agonist, tizanidine, that is a alpha-2 adrenergic agonist, are for spasticity. gabapentin, pregabalin, that are calcium channel modulators, are for neuropathic pain. Anticholinergics such as oxybutynin is for bladder dysfunction. Likewise, personalized treatment selection is developing in this century. The choice of DMTs is based on individual patient characteristics, including disease severity, comorbidities and contraindications, lifestyle, and patient preference. For disease severity, patients with highly active MS may require escalation to more potent agents, like natalizumab or ocrelizumab. For comorbidities and contraindications, for example, fingolimod is contraindicated in patients with significant cardiac issues. For lifestyle and patient preference, route of administration, such as oral, injectable, or infusion, impacts adherence and quality of life.